Hypernatremia is going to come in the boards. Even if you don't like the topic and you're confused by it, it's going to be there. It's a fact. And the way to evaluate this is to have the urine osm as the central pivot point. If the urine osm is less than 800 milliosms per kilogram in a patient who's hypernatremic, you really need to think about losses of water from the kidneys. And there are two main sources of loss of water from the kidneys: diabetes insipidus and osmotic diuresis. And both questions could be asked of you. So they might ask you something like, give you a history, and you may never have seen a patient with diabetes insipidus in your life, but this might be the first time you'll see one in the boards, but be aware of it. They're going to ask you this. And osmotic diuresis is a really big favorite because all the people who have a modest amount of knowledge about hypernatremia will gravitate to the to the option in the question that centers around DI, and think about osmotic diuresis because that's an important cause of renal water loss. And of course, the hint for that will be either a high glucose level, so the patient will have either significantly hyperglycemic or some evidence of glucosuria on a urine analysis, or the patient is uremic and has a very high BUN, and they're looking for your knowledge around that. They're not going to give you a patient with DI who also has a very high urea level, because that would then be very confusing. And also think about a patient with, who might have been treated with mannitol for a variety of reasons, but the most common scenarios might be a critically ill patient in the ICU with perhaps some cerebral edema who's been treated with mannitol, who becomes hypernatremic. That type of patient might have renal losses of water. And somebody who is able to concentrate their urine appropriately, so the urine osms are greater than 800 milliosms per kilogram. Remember, maximum osmolality is around 1200, so greater than 800 will be 800 to around 1200. Think about insensible water losses, people, for example, who just ran the marathon or something like that, that might be a case. GI water loss in somebody with watery diarrhea, a patient with excessive amount of sodium intake. The most common scenario here will be insensible water losses and GI water losses. Most commonly, hypernatremia develops not from these things alone, but when there is an adequate water intake. So the classic example would be the person running a marathon who's not drinking enough water as they're running the race, and they become, they lose a lot of water and then don't consume water, and they end up being very severely hypernatremic. The management of hypernatremia, the key points are: replace the free water deficit. Just a general rule of thumb is 50% of the first 24 hours and no more than 0.5 millimoles per hour. And anything close to this is going to be the correct answer. So if it's, if they say is 0.55 correct or 0.45, it's close enough to 0.5. That's the general thing. You need to do it slowly, and you need to do it, you need to do about half of it in the first 24 hours. Remember that most patients replace ongoing free water losses is important. So you not only calculate how much the patient has lost, but how much is ongoing loss. And this becomes important in somebody with diarrhea. They are obviously hypernatremic, they've had a significant loss of free water, and you can repair that loss, but they're continuing to lose, so you have to adjust for it by giving them a little bit more. Treat the underlying cause. Desmopressin for cranial diabetes insipidus is the only little pearl you need to remember. But for nephrogenic DI, you can reduce urine output with sodium restriction. You can use thiazides or give supratherapeutic doses of desmopressin to overcome the nephrogenic DI. So those are the key issues there. Likewise with hyponatremia, this is probably the most common electrolyte question that will come up in the boards, and you will get more than one of these questions. And Alan spent a fair amount of time going through this. Just remember 3 points here. One is that you are definitely open to the risk of being presented a normal or pseudo-hyponatremic case. This is because of, and the fact that you know that is just good enough, because you'll ace that question. Increased lipids, so hyperproteinemia and increased serum protein are going to be the two main causes of a pseudo-hyponatremia. In individuals with hyponatremia in the context of elevated plasma osmolality, think about glucose contributing to that, excessive glucose, and at the bottom you see the adjustment, and then mannitol. And then in patients with a low low plasma osmolality, think about hypoosmolal hyponatremia. And then if you think of patients who have hyponatremia in the setting of low osmolality, the commonest thing you'll be asked in the boards is a patient with SIDH. It's going to be a classic. I would be surprised if any one year there wasn't a story of a patient who ultimately the correct answer was SIDH. In patients with a low serum osmolality who have hyponatremia, that's because of a high ADH. And the only question you have to think about is whether the high ADH secretion is occurring appropriately or inappropriately. And if it's occurring appropriately, it's usually because there's a reduced circulating volume. And so you'll be thinking about cases of hypovolemia, either because of renal or extrarenal losses, or an extracellular volume depletion because of heart failure and nephrotic syndrome and liver failure. If the patient doesn't have these two, the most likely scenario is that the patient has SIDH. Another common question is somebody who has primary polydipsia, and this might be a question. They'll give you a patient with, usually it starts off with, this is a 22-year-old person who has psychiatric history, who comes into the hospital with hyponatremia, plasma osmolality is X, and then they'll give you a urine osmolality. And the primary polydipsic patient will be somebody with a very low urine osmolality. The kidney is trying to get rid of as much water as possible, but it's even exceeding the kidney's ability to secrete maximally dilute urine. So that's going to be the primary polydipsic patient. All of these other causes here, the high ADH, are going to be associated with high urine osmolality. So that's the thing to keep in mind, that difference. And so this, in patients where, with hypoosmolal hyponatremia, what you do clinically is volume status. So the case history that you get presented, you look out for clues for what the volume status is, and patients with SIDH are going to be euvolemic or near euvolemia. They're never going to be hypovolemic. They'll either be euvolemic or they may be a little hypervolemic. In other words, they may have a trace of pitting edema at the most. In patients who are hypovolemic, the most common cause is going to be dehydration and diuretics. Those are two most common causes that you'll encounter both in the examination and clinically. And of course, if the patient is edematous, you think about CHF, nephrotic syndrome, and so on. If you get a case of hyponatremia and then they ask you a second question, it'll probably be related to correction of hyponatremia. Hyponatremia is the commonest reason why nephrologists get sued in the United States. And so it finds its way in the boards because correction of it is the main reason, or inadequate or improper correction of it is the main reason that specialists like myself get sued. And the key thing to remember is slow. In patients who are acutely hyponatremic, less than 48 hours, or symptomatic, you could correct a 1 to 2 milliequivalents per hour. But even in those patients, the default position is usually slow. In chronic patients, you do it really quite slowly, at 0.5 milliequivalents per hour. But the key message is the message that Alan, you gave you, which is do not exceed a total correction of 12 milliequivalents per liter in the first day. And don't correct to beyond 120 to 125. One question that sometimes happens in clinical practice, won't come up in the boards, I think, is what happens if you overcorrect? If it's correcting much faster? Well, obviously you slow down the correction, you stop the hypertonic saline, but in other circumstances you might actually have to use DDAVP to sort of slow down the correction, because what you don't want is the syndrome of central pontine myelinolysis, which is devastating to that patient and will end up with neurological deficits and you in a malpractice suit. Hyperkalemia also is very common in the boards, but it's also common in clinical practice, and you just have to remember how you separate it out. Remember, the questions that are most commonly asked will be, in my view, related to cell shifts. You know, a patient who is either on one drug or another, who has hyperkalemia, and you have to sort of use clues in the history to figure out what drug they're taking or why they may be having some shifts. The treatment of hyperkalemia, the key things, this everybody should know. If you don't know this, then you know you're probably a little late in the game as far as the boards. The key things are stabilize the membrane, so use calcium chloride or calcium gluconate. Remember that you shouldn't be giving calcium chloride through a peripheral vein. Increase potassium entry into the cells. This is usually through glucose and insulin. Some people will use albuterol. Usually one doesn't do it in clinical practice simply because you've got a patient with signs of cardiac toxicity. The last thing you want to do is to get their heart rate up, and that's what albuterol will do if you give it to them effectively, so you tend to be cautious. Bicarbonate, remember, bicarbonate doesn't work acutely, it takes time, so you might get a question in the boards about how, where the different options for a person with severe hyperkalemia and what works acutely. The first 2-3 hours, bicarbonate takes much longer than that. Yes, the answer is bicarbonate, but if you really want to correct it quickly, it's going to be insulin dextrose, it's going to be using a resin, it's going to be using dialysis. Hypokalemia, it's important to know the differential diagnosis of hypokalemia. Again, I think here you need to be aware of the causes from a cellular shift perspective, but also GI losses such as vomiting and diarrhea. The most common cause in my experience with upper GI cause for hypokalemia are patients who have an NG tube in, who are not on a PPI, or in a bulimic patient. And what happens here is the potassium loss is not occurring through vomiting. The vomitus itself doesn't have a lot of potassium. The aspirate doesn't have a lot of potassium. What is happening is you're vomiting out a solution that's very acidic, and the kidney is compensating by getting rid of potassium in the urine. And so you might get presented a case of somebody who's undergoing NG suction, who's not on a PPI, who has hypokalemia, and they give you the urine electrolytes, and the urine electrolytes, or they ask you what the urine, what would you predict the urine potassium to be? And on a patient who's on nasogastric suction, not on a PPI, the urine potassium will predictably be high. That's how these patients develop hypokalemia. In diarrhea, on the other hand, the urine potassium will probably be low because most of the potassium is being lost through the GI tract from the lower GI tract, and the diarrheal fluid is rich in potassium. So that's an important thing to remember there. Alan talked to you about various acid-base disorders. You got to know this absolutely backwards for the boards. This is going to be asked of you in every section in nephrology that comes in every year of the boards, but it'll also, for the cross-discipline questions, the ones where there might be an ICU patient with an abnormal, acid-base parameters, or it might be somebody who has, in the GI section with someone who is an acidosis. So you got to know this. These are the mnemonics for the high anion gap metabolic acidosis. Mud piles, we've learned this since medical school. Just revisit it in your mind. And remember these other causes on the other side of the table. If you have a non-gap metabolic acidosis, it's either going to be due to diarrhea or it's going to be due to a renal tubule acidosis. How many people, just as a show of hands, have seen a patient clinically with renal tubule acidosis? Just raise your hand. Clinically, not in the boards. So maybe out of this room of 400 people, about 100. When you finish the boards, every one of you would have seen a case of this, because it's going to be asked in the boards. Just get over it. You're going to have a question. Master it. All you need to know is what Alan presented to you. That's pretty much all you'll need to know of how to sort it out. And remember, there are basically 3 types you have to remember: a classic distal, a proximal, or a hyporeninemic hypoaldosteronism. If they don't ask you about the type 1 or type 2, they're going to ask you of type 4. And in type 4, you just got to remember there's a bunch of drugs that do it, right? That's the key. So how do you distinguish this? This is how this is a very simple table, and you should be able to memorize this. If you haven't memorized this table, please do so between the hours of 11 p.m. tonight and midnight. memorize this table because it's absolutely critical. You will get that one question on RTA absolutely right. This is the table to remember. Remember, if it's proximal or classical distal, it's going to be a patient with hypokalemia. And if it's type 4, hyporeninemic hypoaldo, it's going to be a hyperkalemic patient, and it's not going to be subtle. It's going to be 3 versus 5.8 or 6, right? So that's, and so if you see somebody with a potassium of 5.8, 6, it's not going to be a patient with either proximal or a classical distal RTA. The urine pH is given. The proximal RTA, Fanconi syndrome, described by Guido Fanconi. Here you might get a case presented where it's a patient has a low potassium. They present you some disease like Sjögren's syndrome or some other autoimmune disease, and then they give you the urinalysis, and the clue in the urinalysis is it's positive for glucose, right? That will be the clue, because why is a patient with this problem got glucosuria? And low potassium with an abnormal urinalysis on the dipstick with glucosuria should make you think about it. If they're kind, they'll give you the phosphorus, which will also be low, or the magnesium, which might also be low. So that's acid base and electrolytes in 10 minutes. Let's move along to definition of acute kidney injury. In all the 25 years I've practiced as a nephrologist, I continue to be surprised every year that nephrologists still haven't figured out what the definition of acute kidney injury is. The most effective thing we've done is change the name, but we haven't come to a clear consensus. And if you guys are confused, it's obvious that we haven't done a good job, because there are 3 different bodies giving 3 different definitions of acute kidney injury. The reality is, if it walks like a duck, quacks like a duck, it is a duck. We all know what acute kidney injury is. The most effective, clinically relevant definition is if somebody has greater than 0.3 milligrams per deciliter rise in serum creatinine over 24 hours. Anybody with that in the boards, you have to wonder that that patient has acute kidney injury, right? Because for the boards, that is the definition of acute kidney injury. In clinical practice, I'm not sure that most people, when watching these patients in-house, keep defining these patients as acute kidney injuries because they have a slight bump in their creatinine. So I think, this is a good definition for the boards. In clinical practice, we tend to see patients with much greater bumps in serum creatinine before we get asked to consult on these patients. And I understand that, because we will be getting 30 consults a day if it's just 0.3. So this perhaps is one of the sources of problems. I think the most obvious definition is how do you know somebody has acute kidney injury, acute kidney failure? Yeah, they've got reduced clearance of toxins, they've got to increase their BUN creatinine, there's some acid base abnormalities, they're a little volume overloaded. How do you treat these patients? We in clinical practice tend to treat them with diuretics. We tend to flush their kidneys out, try and get rid of some obstructing casts if they're there. We try to adjust down the dose of medications, because if medications are excreted by the kidneys, that level of that drug will build up, so you cut that down, you get them off nephrotoxic agents, et cetera, et cetera. And if things are not getting better, these patients end up on dialysis. How do you evaluate this? Why am I showing you these very simple slides? Because you're going to get presented with patients with acute kidney injury as cases. They're not going to say in the board, the definition of acute kidney injury is A, this number, B, this number. That's not going to happen. Even if you were hoping that, it's not going to happen. What will happen is that you will get a patient presented to you, and you're going to have to figure it out a little bit, be challenged by looking at the case presentation. And how do you figure it out? Well, you ask simple questions. Did the rise in creatinine occur acutely? And then you try and look for causes. The causes that you should worry about are over-the-counter drugs like non-steroidals, very much of a favorite in the boards. Somebody was being, a 42-year-old person has lots of joint aches and pains, ends up being treated with indomethacin, et cetera, and then gets admitted to the hospital, bump in creatinine, and you've got to try and figure out what's going on. Well, the cause is probably going to be the non-steroidal. Contrast agents, hypotension, et cetera. How do you know whether this person has acute kidney injury versus something they had before? What are the clues? Well, you look for data from the past, so you might see that in the presentation. You look for a renal ultrasound. The patient has relatively small kidneys. And you might say, well, I don't remember, and I can't, between now and the boards, memorize everything. I'm not going to be able to memorize what a normal kidney size is, right? What I'm telling you is that it's not going to be subtle. They're not going to give you kidney size of 9.5 centimeters, where 9.8 and above is normal. It's going to be, the kidneys were 7 centimeters in size, which are small kidneys. So, it's going to be clear-cut shrinkage of kidneys to give you a hint that this patient has chronic disease. Whenever you get presented a case, look at the medications. We are always amazed when we get patients on the inpatient side that the referring doc hasn't figured out that the drug might be responsible. The drug they gave to the patient may be responsible, so always worry about that. Social history, the things that you need to worry about are IV drug abuse. Cocaine, for example, can be associated with a very severe vasospasm to the kidneys and can cause acute kidney injury. Levimazole, which is used to cut these drugs, can be used, can cause acute kidney injury. These are the sort of key drug things that are important. Physical exam, the key thing you're looking for is this a primary disorder of the kidney, or is it part of some systemic problem? So if the patient has a rash, the patient has other things going on systemically, then the kidney is a bystander, and the cause of this is going to be related to whatever's causing the rash and the other organ involvement. Lab data, Brad Denker talked, and also Suswaker talked to you about. I talked to you about the renal ultrasound. We always do a renal ultrasound in the workup of these patients to look at kidney size and rule out obstruction. This I'm not going to spend any time on. This is I don't think they're going to ask you in the boards, and most people in clinical practice don't start doing a lot of these. The only one that I find particularly useful is the fractional excretion of sodium, because prerenal patients have low sodium excretion. But remember that the low sodium excretion of less than 1% fractional excretion of sodium is normal in normal settings. All of you here have a fractional excretion of sodium of less than 1%, almost everybody, except for the people in the bathroom, because you are preserving most of the sodium. If you lost sodium at a much higher rate, you would be volume contracting, you'd be going out there, peeing that stuff out and then drinking salty water. So most of us preserve sodium very efficiently. So fractional excretion of sodium of less than 1% is relevant contextually in a patient who has a history and a physical exam suggestive of acute kidney injury. Then a low fractional excretion of sodium suggests it's prerenal in origin. In somebody who has a low fractional excretion of sodium, who is on a diuretic, sometimes you might need to use something called an FE-urea, the fractional excretion of urea. That's probably a little too advanced for the boards, but just remember, to figure that out, there's another fractional excretion equation that's useful. On the bottom right side is the muddy brown cast, which if you get an image with this would be the image. This doesn't look very muddy to me, but they can be these granular casts. Usually if you get it in the boards, it's going to be muddy. And it's going to be mud that you see, dark black mud, not this lighter stuff. Management of ATN, prevention, there's really no proven role for diuretics, dopamine, or calcium channel blockers. Some patients you might alkalinize the urine, particularly if they have tumor lysis syndrome in a patient who has a very high uric acid level, or somebody with suspected rhabdo. In established ATN, while the official word is that there's no proven role for diuretics, most of us use diuretics as a trial basis to try and induce the patient from oliguria to normal urine function. Fluid and electrolyte treatment in AKI, this is just a long list. Key things are just correct what's abnormal. And so if they're hyperkalemic, you correct that. If they've got metabolic acidosis, you correct that, etc. Complications, these are some of the lists of complications, mostly fairly self-explanatory. Probably not going to be asked any questions related to this at all. Indications for dialysis, this is a list that's given to you from medical school onwards. The key thing here is you could put intractable in front of everything, or refractory against everything. So most times patients with acute kidney injury get started on dialysis or renal replacement therapy if they have hyperkalemia that's not correctable, if they have volume overload that's not medically correctable, etc., etc. There are in the ICU type questions on the boards, questions related to continuous veno-venous hemofiltration. That's basically using a pump that pumps blood at a slower rate, and this appears to be hemodynamically better tolerated. There hasn't been any clear-cut studies showing it's better than intermittent hemodialysis, but for the most part in the United States, hemodynamically unstable patients with acute kidney injury who require renal replacement end up on CVVH. It's more expensive and you need specialized equipment, so it's not necessarily available in every ICU in the US. Kevin Tucker talked to you about stages of kidney disease. These are just some of the stages. I don't think you're going to be asked a question about, what GFR corresponds to stage 3 kidney disease. You're not going to be asked that. You just need to be aware that there are stages of kidney disease and that the estimated GFR using a prediction equation is what's used. This slide depicts what the causes of end-stage renal disease are in the United States. This question ends up getting asked every year in the boards, almost. What's the commonest cause of end-stage renal disease in the United States? Is diabetes. And it has been for many years, and they ask you that. It's an easy question, slam dunk if you ask me. Well, how do you measure kidney function? The message out there is you need to use a prediction equation. In this day and age, that's what most people should be doing in clinical practice. You don't really need to know what type of prediction equation, other than know that it has to be an equation. For your own benefit, it's an MDRD equation. You don't need to know what MDRD stands for, just remember MDRD. There are newer equations, CKD-EPI, and the New England Journal of July 5th, there was a cystatin and CKD-EPI equation that was published for people with borderline kidney function. That's not going to be in the boards. But you need to remember, use an equation and use it to classify patients. Complications of kidney disease, you might be asked about anemia, hypertension, and bone disease. Anemia, the key thing to remember is that you don't want to correct to normal, the hemoglobin, because now there's consensus that correcting the hemoglobin to normal with ESA is associated with increased risk. For the most part, what you're ending up is hemoglobins between 9 to 11 is what your target is going to be, and treating patients if they're symptomatic. In patients with hypertension, you're going to be aiming for JNC7 as your guideline or guidepost, and it's less than 130/80, and you're going to use an ACE inhibitor or an ARB as your first-line therapy. Patients with bone disease, you're going to treat these. Firstly, you're going to check a PTH if you have a patient with chronic kidney disease. You're going to follow the calcium-phosphorus ratio. You're going to aim for less than 55, and a PTH level. If it's elevated, you're going to be treating those patients. If it's markedly elevated, at least 3 times to 5 times normal, you're going to be using some sort of vitamin D product, usually an activated form of vitamin D. Brad Denker talked to you about proteinuria, but there are different things you need to consider with proteinuria. Sources, very permeable glomeruli, tubular overflow, impaired absorption of albumin by the tubules, a lower urinary tract disease, and then fever, exertion, CHF, and trauma. Mostly put out of your mind lower, a urinary tract infection, fever, exertion, CHF, or trauma as a cause of significant albuminuria. If you see somebody with significant albuminuria greater than 2+, 3+, more than 500 milligrams to a gram, it's going to be either tubular or glomerular. Urinary tract infections don't cause a gram of protein in the urine. Proteinuria, you'll notice that we as nephrologists interchange the use of albuminuria and proteinuria, but you all know that we're just doing that in a loose fashion. Not all proteinuria is albumin, right? There's in the urine, when you check for protein, there's 60% of it is albumin, and the rest of it are tubular proteins of various types. But what's measured in the dipstick by the dipstick is albumin, not protein. And roughly, 4+ of albumin is substantial amount of albuminuria. When you have trace to 1+, you're really talking about, in a diabetic, for example, you're talking about established microalbuminuria, usually in the higher end, above 200 milligrams of albumin in the urine. Other ways to measure albuminuria or proteinuria is albumin to creatinine ratio, which is what's recommended by the American Diabetes Association in all type 2 diabetics at the time that they're diagnosed with type 2 diabetes. Brad talked to you about the different forms or categories of proteinuria. This slide just depicts for you that patients with more milder proteinuria may have it for a variety of different reasons. The most common one for the boards is going to be orthostatic proteinuria. In patients with more significant proteinuria or albuminuria, 1 to 3 grams, think of a mild glomerular process or think of tubular disease. Patients with greater than 3 grams, you'll be thinking about glomerular disease. So if you have a case presented to you in the boards where somebody has more than 3 grams of albumin in the urine per 24 hours, that's going to most likely be a glomerular cause. That's not going to be, fever or orthostatic proteinuria. In patients with significant albuminuria, you might be presented with a syndrome of nephrotic syndrome, which is defined here as greater than 3.5 grams of protein per day, hypoalbuminemia, increased lipids in the urine, edema, and an abnormal urine if it's abnormal, with fatty cast, free fat, and oval fat bodies. That's what nephrotic syndrome is clinically. It can have different complications. The most common will be edema. Sometimes patients can be hypovolemic because they just haven't got enough oncotic pressure and they develop acute kidney injury. Thromboembolic events, if they're wasting a lot of their coagulation proteins in the urine, they'll get abnormalities in the balance of coagulation proteins and they may become thromboembolic. Infections, again, if they're wasting through the urine a lot of protective immunoglobulins, they may become at increased risk of infections. Fanconi syndrome, if the amount of proteinuria damages the tubules, they may develop subtle abnormalities of tubular physiology, such as wasting of potassium and magnesium. Atherosclerosis, because they have very high lipids on the long run, this might be a problem, and then malnutrition. The main things to remember in the etiology, divided into primary causes and secondary causes of nephrotic syndrome. The most important primary causes are membranous and FSGS in adults. In the US, the most common cause, particularly in urban populations, is FSGS, focal segmental glomerulosclerosis. You might be asked about that. In patients where you're not given a choice that it could be FSGS, then the second most common is membranous. If you get a patient who has nephrotic syndrome with a cancer, most likely it's membranous, particularly if it's a solid tumor. So those are the little hints. Younger people are prone to get minimal change disease, particularly adolescents. And these patients are going to have a steroid-responsive nephrotic syndrome that presents, and it's going to usually be a younger person, although not exclusively so. Secondary causes are very commonly asked about in the boards, and the list is long. The key things to remember that are commonly asked: non-steroidals is a common medication cause of nephrotic syndrome. Gold treatment in a patient with rheumatoid arthritis who develops nephrotic syndrome. Gold is the cause of a membranous form of nephrotic syndrome. Cancers of various types, lung, colon, stomach, are associated with membranous, secondary membranous. Autoimmune diseases, and then metabolic diseases, diabetes is a common cause. When you look at patients, either on the boards or in clinical practice, remember the history is important, and these are the things that you look for in the history. These are the clues. For diabetes, you look in the eyes. For retinopathy, or you might be presented a case where somebody has background changes, and look for neuropathy. Look for clinical abnormalities suggestive of lupus, such as joint aches and pains and a rash. In amyloid patients, you look for paraproteinemia, so if they have a Benz-Jones proteinuria. Infection, you look for HIV risk factors, you look for hepatitis serologically, syphilis clinically or serologically, endocarditis, whether there's something in the history suggestive of it, or a cardiac ultrasound that suggests endocarditis. Medications, as I said, the two common ones for the boards are non-steroidals and gold. Malignancies, Hodgkin's, and solid tumors of any type. You might get presented a case with that as a nephrotic syndrome. Family history, there are familial causes of nephrotic syndrome, but I don't think for the internal medicine board you'll be asked about it, and I don't think they'll ask you about pyelonephritis as a cause of nephrotic syndrome. The physical exam, you try and distinguish whether it's primary nephrotic syndrome or secondary. So primary is going to be people who have otherwise a normal physical exam except for some edema. Secondary are going to be people with rashes or joint problems or other stigmata of disease like HIV or syphilis. In lab data, the things you should be looking for, you check the urine sediment, usually bland, or it has fat or fatty casts in it. You check the BUN and creatinine, you look at liver function tests, you look for glucose and hemoglobin A1C, you do a 24-hour or urine albumin to creatinine ratio, you do an ultrasound of the kidneys, see if the kidneys are enlarged in an infiltrative process or an amyloid, and then you do serological tests, look for activation of the classical or alternative pathway of complement, you look for ANA, patient, for example, with lupus, you do an HIV test, you do hepatitis serologies, you look for abnormalities suggestive of a paraproteinemia. Treatment can be divided mostly into two categories: treatment general, angiotensin blockade, ACE inhibitors, or angiotensin receptor blockers. Most people don't restrict protein, but it's an option to slow progression of kidney disease in the setting. The reason you don't do it in nephrotic syndrome, they're already losing a lot of protein. They may be a little malnourished. To further restrict protein in them might actually make things worse. Blood pressure control is obviously important generically, and anybody who's got hypertension is important to do that. Non-steroidals, you don't use non-steroidals in an acute setting. It may give them renal failure. Non-steroidals can reduce proteinuria by reducing GFR, but reducing GFR is sort of, throwing the baby out with the bathwater. You don't want to reduce GFR to get rid of proteinuria. You want to reduce the proteinuria particularly. And then more specific therapies, there are a whole bunch of new things. You aren't going to be asked about them in the internal medicine boards, but if you are, almost everybody ends up getting a trial of steroids and then some form of chemotherapy. And again, the details I don't think are important at this stage. Causes of hematuria were discussed. Basically for the boards, what you're going to, if you get presented with a patient with microscopic hematuria, what you're going to have to figure out is, does this patient have an epithelial cell malignancy? And usually people with an epithelial cell malignancy, such as a renal cell CA, are going to be people over the age of 40 or 45. Young people generally do not get renal cancers. It's usually people with risk factors. They're going to be people who are smoker, people who've been exposed to radiation or some form of toxic drug. It's going to be that type of patient with strong family history. So that's the first thing. The second is, if you do get a person with hematuria, ask the question what the hematuria is traveling with. If the hematuria, the blood in the urine, is traveling with albuminuria, that suggests a glomerular process. Usually cancers or epithelial sources or even infections are not associated with significant amounts of albuminuria. So if you have albuminuria and it's significant with hematuria, think about glomerular disease or even to a certain degree interstitial disease or vascular disease, but it's not going to be an epithelial cell malignancy. And that's the main thing to worry about, is to try and what do you do for diagnosis of epithelial cell malignancy? Most people would say an ultrasound would be your first line therapy. In patients with normal kidney function, you might do a spiral CT or you might do a CT with contrast to just look and exclude small tumors. How do you tell a simple cyst from a malignant cyst? You look for calcification, you look for septation, you look for if the cyst looks abnormal. That's pretty much all you need to know, how to separate those two things. Because in practice, if you see somebody with hematuria, you have to decide who you're going to refer the patient to, a nephrologist or a urologist. And if you think it's an epithelial cell malignancy, you're going to tend to send the patient to a urologist. This just shows you how you work your way through this. History, physical exam, UA sediment. You might do some 24-hour estimations of calcium and uric acid, because sometimes these can be associated with small amounts of blood. But you're going to do a CT with contrast, a spiral CT. You might do early morning urine cytologies to look for abnormal urine cell morphology, suggesting perhaps a bladder CA or a renal cell CA. In a patient who has abnormal looking red cells, dysmorphic red cells, and albuminuria, the things you're going to do are either observe the patient, they may have IgA nephropathy or some sort of benign hematuria syndrome, or quite possibly, a renal biopsy. So you want to distinguish these two arms. This arm of patient with the dysmorphic red cells is going to go to see a nephrologist. This person might end up being either treated by yourself or seeing a urologist.